Welcome, everyone. My name is Josie Lee, and I'm a research coordinator at the U of M Department of Family Medicine and Center for Disability Health and Wellness. We are excited about the new Disability Health Objective Structure Clinical Exam, also known as OSCE. We have completed several scheduled trainings to help prepare for the upcoming OSCE event, which will take place at Taubman Health Sciences, the SELA facilities, in early April this year. This pilot program is supported by the Research and Training Center, Advancing Health Equity Among Adults with Disabilities from Diverse Communities, AHEAD DC. This center is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, NIDILRR, and aims to examine and address systemic issues in healthcare that negatively affect people with disability with intersecting identities, who are more likely to experience compounding inequities, discrimination, and health disparities. So this meeting is in part of a series of panel discussions on how to care for people with disabilities from a variety of disabilities. This will provide some training tips and patient insights that will be part of the upcoming disability-based OSCE exam. We have caption available for anyone who needs it. We are thrilled to have our panelists Laura Hall and Dr. Gianna Rodriguez join us today. So Laura Hall is a passionate disability self-advocate to the Michigan area, having completed her bachelor's and master's in social work at Michigan State. Since then, she has worked at the Michigan Disability Rights Coalition as a program director and assistive technology specialist. Her longstanding advocacy focuses on general accessibility and empowerment and the adoption of technology to provide assistive support. And for those who are interested after this session, a lot of her work can be read through her articles posted on MDRC's website. Dr. Rodriguez is the director of the Spinal Cord Injury Program in the Department of Physical Medicine and Rehabilitation at Michigan Medicine. She is the medical director of the Wheelchair Seating Program and SCI Fellowship Program. Her research focuses on SCI heavily, and she serves on international standards and autonomic standards committees, where she does advising for development of any new standard documents and the improvement of existing neurological and autonomic standards. So welcome to our panelists. I'm going to pass it over to Laura first to provide some patient perspectives from her experiences.
Hey, thanks, Josie. Hi, everyone. My name is Laura Hall. Um, I am 42 years old. I have cerebral palsy, spastic cerebral palsy, so I use a wheelchair, power wheelchair. I have a service dog, and all those kind of interact with my interactions with the medical system. So I thought I would mention them. So I've had quite a bit of medical intervention in my life, as I think a lot of people with disabilities either have or have not due to some of the disparities that Josie talked about. I remember going to U of M for my visits when I was a kid and just not really feeling like I was a part of the visits as a child, like not really knowing what was happening, what was going on. I would have a lot of surgeries as a kid, and so I spent a lot of my summers, recuperating and just thinking about that system and how I never really felt as though clinicians like interacted with me as I was younger. And then fast forwarding to as I get into adulthood, needing to kind of find my own way around the medical system has been a challenge. Um, I think I initially wanted to find uh, a clinician that could address my cerebral palsy and help me with things regarding that. And then it just kind of grew and became bigger from there. So I have struggled to find like a medical home, which I think is something to think about when you're working with people with disabilities because um, transportation is an issue, access is an issue. So even thinking about what do you see when you get there to the front door? Is there enough parking? Is there a power door button? I think about everything from the moment that I roll up to the building that and to the moment that I roll out. And so just kind of thinking about that. So what is the physical structure like when I roll into the office? Is the reception desk, up high? Um, Takes me longer to fill out forms just because it takes me a little bit longer to write, and I feel like I never get those completed. And so I don't know if everybody gets the full medical history on me. Um, and it wasn't until I came to the U of M system actually that I feel like I kind of found a medical home. I had a doctor in the U of M physical medicine and rehab department who was overseeing my care for my CP and then also started connecting me to specialists that could help me with issues that were related to the CP and not related to the CP. And so now I have a seating specialist, a urologist, you know, respiratory therapist, all sorts of things. But what I'm still struggling with is finding that primary care doctor in my area that's accessible to me and I feel like would really be able to address my day-to-day concerns, maybe not related to my disability, maybe related to my disability. Um, some things in my adulthood that I found challenging is, again, the transportation. A lot of medical offices now are saving appointments for patients that call in and they're sick. I think this is where I really struggle. Like I come down with a cold or something, I'm sick, I'm looking to go to the doctor. Um, and they now have like same day appointments, which are great. But if you don't have any way to get there and you can't schedule transportation for the same day, that doesn't really do you any good. And then they want you to call the morning up to get an appointment. And so I just think allowing some flexibility with those kind of things could really help as well. Um, I've learned through being a participant in this project that there's a lot to think about when you're looking at people with disabilities. Even we've found a challenge just in the program, needing a Hoyer lift to get me on the exam table, and that's something that I've never had before in the doctor's office. But in order to do a complete physical exam, I think it's necessary. And so I can't tell you that I think I've ever really experienced a full physical exam and know what that would be like. And so I'm looking forward to our patient sessions when I have an opportunity to meet with medical students and kind of go through some of those things. So I guess just in kind of closing of this remarks, I think if you think about everyone and their needs, it can be overwhelming. But when you think about all people at the same time, you're also checking a lot of the boxes for access and accessibility. So if things are easier for people to read that have low vision, they're going to be easier for me to read as a patient. Or if there's assistance helping with the paperwork, that not only helps people that are blind or might have low vision, but it can also help people with physical disabilities. So just thinking about all of those access points that people have, when going to get medical treatment and how can you think about that more expansively to include more people. I don't know if you have any questions to follow that up, but
Yeah, thanks for sharing, Laura. We're gonna save questions for the end
okay.
so everyone can address. Um, so we'll pass over to Dr. Rodriguez.
Thank you for having me today. This is an area where, I really wish the medical students sort of like get into and spend more time in learning. Okay. I know that as medical students, you don't necessarily get a whole lot of exposure right off the bat. But I think as you mature in your medical career, more and more, depending on, which path you take, you will encounter patients with disabilities. And also in your own personal lives, I think as you mature yourself in your own personal lives, you'll have friends, family members, and things like that that will end up with one disability or the other. So it will be important to help direct care or for yourselves if you directly if you will provide direct care to people with disabilities, you will need to learn how to essentially approach, approach patients. And, again, on my end, I take care of people with quadriplegia or paraplegia. And then I also know that, within my patient structure or my patient umbrella, I have those who are less, with less physical disability and, those with more. So depending on how complete or incomplete the injury is. So I think that when a medical provider first sees a patient, you will have to go in with some knowledge and education on what the diagnosis is, first and foremost, okay, and what specific disability is affecting the person, right? And you can do a chart review for one. And then obviously when a patient comes in to see you, you'll get a little more sense of where that patient's function is. And so obviously as physical medicine and rehab providers, we focus on function, and we try to facilitate a function that's as independent as possible, wherever the patient falls in that spectrum of of disability. And then also I think it's important for medical students to know that it's not just about the mobility aspect or the inability to or the need for assistance overall. Okay, it's also about all the other medical comorbidities that come with with a patient and a disability as well. So like, for example, a patient with spinal cord injury is not just about the mobility issues, but it's also about neurogenic bowel, neurogenic bladder, breathing issues, bowel issues, cardiac issues. So knowing that up front, that it's not just about the mobility issues, is also important. And then skin is a big one too, before I forget, skin, etc. So in terms of, I think as providers, we really want our patients to open up to us as best as possible, so that there's open communication, so that we know how to be able to provide the maximum care or the most optimal care to our patients. And so opening up conversation to begin with, getting the patient comfortable, is very important. Sort of like not necessarily right away focusing on, okay, let's get into medical stuff, getting to know the patient a little bit more personally, even with a few minutes, I think is helpful. Because it also helps me, it also helps the provider sort of like not just see the patient as a patient, but see the patient as a whole, with their families and, where they are, social wise and things like that. So, and then, if let's say the patient comes in and is more involved, I think you'll always want to maintain more involved and coming in with a family member or a caregiver. Okay, you will have to address the patient directly first before you actually ask the input of whoever the caregiver is, family member or friend with the patient. So it's always the patient first that you need to communicate with directly. And then also, if you notice that the patient is having difficulty with understanding you or with your explanation or whatever, you try to break things down in a simpler manner. For example, they come in with a clogged catheter or something like that, and they're not necessarily understanding that the catheter has to be flushed. You go in and say, well, you create boogers in the catheter, and you kind of have to eliminate the boogers with flushing, just to simplify things based on where the patient's at, so that they buy into your recommendations for their health, because I think that's important. And it really is a partnership. So you have to have them understand why you're doing what you're doing. And a lot of what I do is I educate and educate and educate because again, it's important for our patients to understand why we're doing the things that we're doing in the first place. And then also, trying to confirm that the patient understands what you're saying. And hopefully, if the patient says yes, then that truly is the case, is helpful. The other thing too is when you're speaking to people with disabilities, you always see the person first. So for example, you address the patient with, or as you describe the patient, even in your notes, it's like the person with disability or the person with spinal cord injury. You don't necessarily use the term quadriplegic to identify the person. You use the person apart from the disability. So the disability is there, but it's a person with disability. So I always say person with cervical spinal cord injury, or a person with, for example, cerebral palsy. And then also, so presume that the patients with disabilities are competent to handle their own medical care. And if patients do not have anyone to assist them, you can offer your help, but you don't necessarily ask them if, hey, did you bring somebody else right off the bat? You sort of like try to find out where the patient is in the whole scheme of things with regards to making decisions for themselves, or assuming the assistance that the patient needs. So you offer the assistance and wait for the offer to be accepted, and wait for instructions specifically from the patients as to, because I think our tendency is to want to jump in and help, like for example, with transfers. But, I always say, okay, do you need help with your transfer? And if the patient says, yes, I need help. So then, okay, I will, facilitate help for the transfer. But if they say, I'm okay, I can do this myself, and, I just need one thing or the other, then I'm like, okay, please just cue me how you want things done. Okay. So even when they say I need help, I ask them, how do you want me to help? How do you want me to, so some people say, okay, let me move let me transfer myself onto the mat, and then can you please help me with my legs? I'm like, okay, how do you want me to help you with your legs? Or can you please position my wheelchair in a certain way? So everybody has different ways of, let's say, doing a transfer. Knowing how the patient wants you to be of assistance when they do accept your assistance is also important. And then, so obviously it's helpful if the facility, like Laura was saying, in and of itself is accessible altogether, so we want to ensure that the place or the clinic that we're seeing our patients at is completely accessible. So, these specifically, this includes tables that can go up and down, okay, and rooms that have enough space so that turning radius, let's say, in a wheelchair is not too difficult. And then also, access to bathrooms. Let's say, we want to make sure that the bathroom is accessible, you know, and I always go to wheelchair accessibility because obviously it's the equipment that needs most space, right? Versus a walker or a cane. So when we say wheelchair access, that sort of like covers the other assistive devices that patients might be using. Obviously, you know, making sure that it's ramped, you know, that steps are not an issue, that, you know, if let's say the clinics are on the second floor, that there are elevators, that there are accessible parking spaces. And then, you know, as a provider as well, sort of like getting familiar. And of course, like, you know, I am a physical medicine and rehab physician. I know this stuff, right? You know, with regards to assistive devices, I know what a walker is, wheelchairs, different kinds of crutches, and, you know, there's also different kinds of walkers, there's different kinds of wheelchairs, etc. So sort of like getting familiar, if you're not really going to get into a field where you're providing care to people with disabilities, at least getting familiar with, you know, with assistive devices for the most part in general will be helpful, particularly for primary care providers. Just knowing in general what these are will be helpful to the patients. Also because when a patient come in with their assistive devices, these devices are actually an extension of themselves, because they use the devices to keep themselves safe. And then also they use the devices to increase, you know, their mobility, increase what they can do, right? So, you know, it's important to accommodate for the devices as well, so that the patients are made most comfortable when you see them, you know, in the clinic. So, you know, whether it be a wheelchair or a walker or whatnot, making space is important. So for example, you know, your clinic room, you see that a chair is obstructing as a patient, you know, and you know that the patient is coming in, let's say with a walker or a wheelchair, then you move, you know, the chair aside. Just things like that. You know, making sure that the corridors are clear, making sure that the doorways are clear as well, so that, you know, the patients can come in with ease. The other thing too is, you know, I trained under a mentor who, like myself, subspecialized in spinal cord injury, and he had a spinal cord injury himself. So one thing is, you never say a patient is wheelchair bound or bed bound, or, you know, you always say the person is a wheelchair user. And, you know, as like he said, the wheelchair actually is freeing to him, because it allows him to be as independent as possible. It allows him to go from point A to point Z, you know, with more ease. So it's actually freeing. It doesn't, you know, it doesn't entrap him. It frees him, because it's allowed him to, you know, even go through medical school and become a physician. And so, you know, I always cringe when I hear that term, wheelchair bound. So like making people aware, and you know, I think a lot of people don't mean it that way. I think with education and with making people aware of how to use appropriate terms, makes it, you know, more friendly to people who do use wheelchairs or people who do use other assistive devices as well. I think, you know, knowing where they want the equipment to be in relation to where they're sitting in the clinic is also important. For example, you have the patient transfer onto the mat table or onto the examining table, asking them, okay, can I put this walker or can I put this wheelchair? Let's say where you think it's most appropriate. And if they say yes, then well and good. And if they say no, I'd like it, like right by me, then, respect that. Because again, it's an extension of themselves. If they want it close to them, as much as possible, then that's the way they're most comfortable with it. So unless unless it will obstruct what you're doing in terms of physical examination, it should be no issue. As with any other, going into like a physical examination of a person with disability, you will need to use physical examination techniques that can accommodate the patient's disability. So, as best as possible, and it depends too on what the reason the patient is actually coming to you for. So with that said, if let's say you need to examine, number one, ask the patient, are we able to transfer you onto the table? So it's always with their permission. Are we able to transfer you over to the table to be examined? And for example, the patient came to you for a wound. I'm like, so the suggestion is, okay, I think we'll need to get you on the table to examine your wound. I will not be able to appropriately provide good recommendations if I don't see the wound. Is it okay if I transfer you over to see the wound? Or if it's like an abdominal issue, and you need to palpate the abdomen and evaluate the abdomen appropriately. Again, sort of like always preparing the patient for, okay, this is what I'm going to do. I'm doing this for this reason is always going to be, it's going to always help the patient with, okay, this is why, so that they understand why you're doing what you're doing. So, and some people like refuse to get out of their chairs. I'm like, okay, I'll do the best I can as much as possible with trying to evaluate you in your chair. I think being in the medical field, we want to embody empathy and sensitivity all the time, specifically and especially for people with disabilities. And I think just keeping in the back of our mind the different challenges that our patients with disabilities help or have with their day-to-day lives is important, because then and for example, you're recommending in my case, I have to talk about the bowels a lot. Okay. And there are bowel programs that we come up with. But obviously, I think with every plan and recommendation, you try to include the patient in the decision making or the program, so that it works well as well, or so that they're most compliant. So for example, I say, okay, the best ways to have you have a good bowel movement daily. And the patient says, I don't think I can do it daily. I'm like, okay, let's do every other day then. And explaining to them that, okay, the longest that we can go is either every other day or at the most every 2 days before we need to, get aggressive with their bowel regimen. So having them get involved and also having them sort of like think of what their daily routine is, and sort of like trying to come up with a plan, brainstorm with you what the best possible way, your recommendations will fit into the plan, like their daily routine is important. Again, so that, because we're there to help, right? We're there to keep patients as healthy as possible. And we want them to be compliant with recommendations. And so when they're part of the decision making or the designer of the plan, then that's most helpful to them specifically, because they're actually the main person in coming to see you. So ask for input as mentioned. And then, they've had like my patients tend to be my patients for life, because a spinal cord injury is a spinal cord injury, and they have it for life. And because of that, like I've had patients who've actually had their spinal cord injuries for longer than they've been, non-spinal cord injured. And, and some of them are aging too. So when things come on, and here you are trying to help them fix the problem, take into consideration what their past experiences have been, and sort of like modifying care, taking into consideration their past experiences, again, sort of like sets things up better for success. And if let's say, I know old habits are hard to break, and I pointed out to being upfront as well and saying, okay, the old way will not necessarily work. We'll have to start thinking about the new way. Can you tell me, based on our education, how this will work for you is important when you're talking about input from them, or making sure that they buy into what you're recommending. And then, I think as I mature in my career myself, I'm always humbled, because with, the more I know, the more I realize that I don't know. So when things sort of like get out of my scope, then I'm like, okay, we really need to get other people involved here. The unique thing about being a spinal cord physician is that we sort of become their primary care physician, because we're subspecialized. That's good in a way, but also we do want to partner with our primary care providers, because there are many other things that we don't know ourselves, right? And then also partnering with other specialists, who need to be around the patient. And sort of like, I find myself being okay, I look at you comprehensively. I try to take care of all your issues as best as possible based on my specialty. But if I need to hook you up with other specialists, then, I will recommend that for you. And, rehab in a way, and caring for a person with disabilities is really a team effort. It's never just one person. It really is a team effort. I work with therapists, with psychologists, with wheelchair providers, and then everyone under the sun, whether it be plastic surgeons. I take care of wounds myself, so I work closely with infectious disease. I work with GI physicians for those who have like major GI problems. What else? GI physicians, gynecologists, urologists, etc. So very closely. And as a provider, I find it my job as well to keep myself updated, as to what's latest. So I make sure that I go for continuing education myself. And I try to stay on top of what's most current so that I can bring that to my patients altogether. So I think in a nutshell, I know I said a lot, so I'll stop there for now. And if there are any questions that that you'd like to bring up, I think it'll be a great time to do so.
Great. Thank you so much, Dr. Rodriguez and Laura, for sharing such valuable tips, insights, and perspectives for medical students who are going through this training and will be working with patients with disabilities. We had several questions from our group, so I'll just start going through them. The first one is for you, Laura. And so you talked about the process of finding your medical home and landing at U of M. And I know Dr. Rodriguez hinted on some really important qualities that a physician should carry, but what do you specifically look for when you're seeking a primary care provider and a specialist to care for you?
I think I'm really looking for someone who listens, um, and listens deeply because, if I'm coming to you and there's a problem, I don't know what the problem is. Sometimes it's disability related, sometimes it's not. So I would look for a doctor who would look at my disability, but also not get laser focused on the disability. Um, Someone who sees me as a whole person. I think Dr. Rodriguez brought that up so beautifully. I like to say that we're all interdependent. And so a lot of the goals of physicians are independence. And I think considering who else is in that person's, um, social network is important. Because if she put me on a bowel program, I would need a personal care assistant. And, that's all related. So that all makes sense. I have a lot of pride in my disability and being who I am, and I take pride in being a person with a disability and all that that means in my community. And so I'd like a physician that would also kind of look at disability from that perspective of this is a different identity that we have, that we take pride in, and that is not a bad thing, capital B, capital T. It's just a difference. And we all live full lives with spouses, children, loved ones, and I think it's important to just look at that whole person, that whole situation, and try to address those things as best you can as a primary care physician. So, um, yeah, I guess listen more than you speak, and look at things from different perspectives, and really respect, the way that I feel about my disability, um, and the person's life, like Dr. Rodriguez said too. I've been, prescribed a lot of physical therapy in my life, and that physical therapy is great, and I love it. But I found myself at one point in my life doing so much physical therapy and trying to do things independently. Then when I started working full time, I couldn't spend 2 hours getting dressed in the morning every day by myself. And so I think that kind of goes back to some things that Dr. Rodriguez said too, like how is this going to work and how are you going to get buy-in with some of the intervention measures that you might recommend. So, yeah.
Absolutely. Thanks for sharing that. Um, And pivoting over to Dr. Rodriguez, you talked a lot about how everyone's disability looks different and what kind of devices they would like to use is different. You also mentioned, clinical spaces being large enough, Hoyer lifts, transfer boards, things like that. So, as students may not always be in a PMR clinic that has accessible features, what are some suggestions you have for students in accessing these resources to be able to support their patients fully? Do you have any suggestions around that?
That's a very hard question. um, I think, for spaces that are not as accessible, you try to make the most and the best out of the space, number one, because that's what you have to work with. So you just try to work with it as best as possible. But also, I think advocating for, you know, for appropriate space and wheelchair accessibility is very important, with, depending on what the practice for them holds in the future, if they're joining a practice that will be caring for people with disabilities a lot, then that's going to be, of utmost importance to make modifications and to ensure that spaces are wheelchair accessible.
Absolutely. And this next question is for both of you. So specifically, Laura, we know you have a really strong background in assessing assistive technology devices and how technology can be a support for people with disabilities. Are there any new and upcoming devices or some tried and true that you would like students to know about? And to you, Dr. Rodriguez, do you know of any that have been really successfully integrated in your clinic or that you've seen a lot in your patients? So let's bring technology into the conversation. We'll start with you, Laura.
Oh, well, the first thing that comes to mind is just how versatile all of our smart tablets and smartphones are now, and how they can be used to help with communication, how they can be used to kind of lay out plans. You can even draw pictures on the iPads and things now. So, I mean, my thought immediately comes to like using the technology that people are already used to using, and can we integrate something in that? For example, like timers, medication reminders. Can you use your smartphone to set up medication reminders to become, more on track with your medications? I think also like advocating for that technology to be in your clinic, like you were saying, is really important if you don't have it. Sometimes communication support can come down to like a simple like communication board that isn't an expensive thing to get. It doesn't always have to be high tech technology. And like kind of looking at what the person is already using, I think is an important place to start. And then how familiar are they with technology? And are there places where they can get more familiar with technology? So, for example, at Michigan Disability Rights Coalition, we are home to the Michigan Assistive Technology Program. And that allows us to have an inventory of thousands of devices and things that we have for different categories of life. People can receive a hands-on demonstration from that from our AT specialists. And then if they're looking to borrow that for a short period of time, they can do that. And sometimes we have longer term loans that we can provide as well. So they can really get a chance to have technology in their hands, in their home, in their own environment, and how they use it. So that would be one resource that I would think of. That is a hard question, though.
Um, I'm going to say, you know, it's great if all our patients are given access to technology. And I think for the most part, people have smartphones at the very least, right? But not everybody still in this day and age has a smartphone. They might have, let's say, like a flip phone, still rather than a smartphone. And again, advocating for resources, like almost like, I think when you need access to medical care, having a smartphone as a base is actually should be, you know, should be an important thing that's provided, I think, by, medical insurance. And that's just me saying it, but it's almost, yeah, it's necessary, okay? Because then with a smartphone, essentially virtual visits can be a way to see your physicians, okay? That's one. And then number two, coordinating your appointments, coordinating having to get to appointments, transportation, medications, etc. Again, can be done through your smartphone, right? Or just looking up resources, the closest pharmacy, or um, a lot of things. I mean, as you know, we do so much now with our phones that it's an extension of ourselves at the same time, right? Then we have specialists who we can lean on to serve, like give us, like you, Laura, probably like the many different apps that can be helpful to patients who might have one thing or the other, whether it be, reminders, or I don't know, for health, like calorie counters or something like that to manage their, let's say, their diabetes or their hyperglycemia. So, and then also like user friendly, or they perhaps can use these apps for function, improving finger function or upper extremity function or things like that. Games that can, for people who have some cognitive issues or are wanting to improve, let's say, memory or cognition or whatnot. There are like a lot of different apps that can be used, right? So I think basically if you have a smartphone, then that's great. And then there are other more simple devices that can also facilitate, safety, let's say, that can be cheap, that can be bought through the internet. We just need guidance from, again, from like occupational therapists or rehab engineers or rehab technologists or people who have experience like Laura to sort of like guide folks to, all right, this device, can help you call for help, and it doesn't cost much, maybe, a few dollars or so. You can get it on Amazon. Just like prompting and cueing is important from those who know more than the average person about, different apps that can be used, whether it be on the phone or on the computer or tablets.
Absolutely. Thank you both for sharing the broad range of how technology can be a support system, both in the clinical setting, but in daily life. And so looking to the future of medicine, how it can make things more accessible. Laura, what are some current barriers that you experience? I know you mentioned sometimes knowing the building layout or having accessible parking or even having enough time to fill out forms can be a barrier. What are some other ones that you can think about? And what are some things that you wish will happen in the future of medicine? And I'll also pose that to you as well, Dr. Rodriguez. What are some things that you are hoping that your students and the fellows that you teach will also grow and implement in our healthcare system one day? So I'll start with you, Laura.
Okay, I'm thinking on this. I really think we took a big step forward during the pandemic years with virtual health and how much more access that gives people with disabilities. And so I see that going even further. I mean, I know now if something breaks on my wheelchair, I can call up the wheelchair seating clinic and show them the problem on my iPhone, and maybe they can order the part, or maybe it's something that can be fixed. And so that saves a lot of time from having to come to the clinic. And so I think more of those things that just allow people to see their doctors virtually is kind of the future that I'm hoping for. I know not everything can be done virtually, and I don't want that to replace face-to-face care with my primary care physician or any other physician, but I do think that it greatly increases access. And I think other than that, I just would kind of point to the intangible things like attitudes and discrimination, just the way that you think about disability, you think about the person, Um, you know, I I wish everyone could take a course on disability pride. I think that would be a really great thing. That's a main kind of focal point in my life. Um, yeah, I don't know. Those are the thoughts for now, but maybe I'll have others. 3D
From my,
printing too. 3D printing can
yeah,
do a lot.
yeah, absolutely. Yes. I think from my end, my wish list is when we recommend something, I wish it is what it is. You recommend that the patient gets it, um, whether it be medication. I mean, there's so much fighting. Like I'm regularly sent, can you please justify, why this patient needs this equipment? It gets very tiring as well. It's like, can you please just take our word for it? I mean, we evaluate the patient, or, some other, how should I say, reviewer. Okay, so there's like layers of people who review what insurance wise, who review what they're going to give the patients. Okay, and it's incredibly frustrating when I am the physician who sees my patient, who see them regularly and say, okay, this patient needs this device or that device, and you know, and another physician who never sees a patient and just looks at the paper says, oh no, and working for the insurance will say, oh no, the patient can't get that. I'm like, how can you say that? You don't even see the patient, you're just looking at a piece of paper. So I wish that, and same thing with medications, whether it be devices, medications, I wish, we can have patients more access, or give patients more access to enough care at home, and prevent our patients from ending up back in the hospital because they didn't have sufficient care at home, particularly those who are more involved, obviously. It's also difficult, and I wish we had, I think in Michigan medicine, we have some of that. I wish we had more, like people who can help coordinate care. Because, when you have an involved disability, you have to sort of like manage, a whole lot of different things, from, you know, appointments to supplies to getting in touch with your physician. It's a lot of self-management things as well that you have to contend with, that I know that people do get pretty pretty overwhelmed with everything that they need to stay on top of so that they keep healthy. And I think case managers, or people who can help, I mean, I'm just calling them case managers, they can be, titled differently. The people have access to people like that, to ease some of the things that they need to keep up with, and so that they can help, and then again, you assume that, we don't want to assume that, oh, it's easy, or it's not complicated. I think the systems put a whole lot of things on our patients, and make it a little difficult to navigate. So those are one of the top in my list.
Yes, thank you so much, both of you, for sharing. So as we're coming to a close, are there any further closing remarks that you would like to share for students who are either starting medical school or even moving on to residency and may work with people with disabilities in their specialty or just in general? Are there any closing remarks for folks?
I think it's an exciting field to go into, working with people with disabilities. I think it's a lot, you could learn a lot from people with disabilities. And, you know, as I've said kind of through the whole thing, just seeing the whole person is my biggest thing. Seeing the person, seeing the way they live, seeing their lives, becoming a part of that person's, you know, support network if you're able to, I think is important.
From my end, I think that, you know, as medical providers, if you practice with a heart and if you care, I think that's the basic thing. When you care enough, you practice with the heart, everything else follows. So why you're a provider for people with disability matters. So you have to ask yourselves, you know, why do you want to be in this field? What is your goal? Why are you doing this? And again, if you answer with your heart and if you care enough, everything else follows.
Well, I want to thank you both, our panelists, for all of your time and care and effort for this session. For students watching, this recording will be made available on the Center for Disability Health and Wellness website. We have a wonderful tip sheet that will be summarizing some key points discussed during this hour. We thank everyone for tuning in, and thank you again to our panelists and our team.
Thank you very much for having us.
Thank you.